Welcome to The Explainer. Today, we are really digging into a concept that has totally reshaped fields from medicine all the way to social work: evidence-based practice. Now, that's a term that gets thrown around a lot, but we're going to break down what it actually means, how it's changed over time, and some of the really important debates that surround it.
All right, so here's our plan. We're going to start with the original definition that really kicked this whole thing off. Then, we'll trace how it evolved into a much more complete model. After that, we'll walk through the 5 practical steps of how it's done. And then, this is the juicy part, we're going to tackle the major academic critiques and controversies. We'll wrap things up by looking at EBP not just as a tool, but as a full-blown social movement.
So, to get a handle on the impact and, frankly, the arguments around EBP, you have to go back to the beginning, back to its original formulation in the 1990s. This first pass at a definition really set the stage for everything that followed. So, this definition right here from Sackett and his colleagues, it was nothing short of revolutionary at the time. It put forward a really clear 2-part job for clinicians. 1, use your own hard-won skill and judgment, your clinical expertise. And 2, you have to combine that with the best possible evidence from rigorous, formal research. I mean, this was a direct challenge to just doing things based on tradition or because that's how we've always done it. But, as soon as people started trying to use this model in the real world, its limits started to show. This early, very research-heavy view well, it was missing something absolutely vital. And that led to a pretty major evolution of the model into something much more holistic. What's so interesting here is how quickly the definition changed. We're talking about just 4 years later. The model brings in this third, absolutely critical piece: patient values. And look, this wasn't just some small edit. This was a fundamental shift, a total rebalancing of the framework. It was an admission that you simply can't make good clinical decisions without considering the client's own unique goals, their preferences, and their life situation. And that brings us to this great visual: the 3-legged stool. The metaphor is just perfect. If any one of these legs is wobbly or missing, the whole thing just tips over, right? You've got the best research evidence as one leg, the clinician's own expertise is the second, and the patient's individual values and preferences, that's the third, and it's just as important as the other two. To do EBP right, you have to have all 3 in balance. That's the only way to have a practice that's both stable and ethical. Okay, so that's the theory, this 3-part model of evidence, expertise, and values. But how do you actually do that? How do practitioners turn that idea into a consistent process day in and day out? Well, that's where the 5 steps of EBP come into play. This is it, the 5 A's, and it's a brilliant roadmap. It all starts with asking a really sharp, focused clinical question. From there, you acquire the research. Then you have to appraise it. Is this actually good evidence? Is it relevant? Then you apply it, always in collaboration with the patient. And finally, you assess the outcome. Did it work? It's a complete loop. Now, to make that first step, the ask step, as powerful as possible, practitioners often use what's called the PICO framework. It's just a way to build a better question. By defining the patient or problem, the intervention you're considering, a potential comparison, and a measurable outcome, you can formulate a question that's so specific it makes finding the right evidence way, way easier. Okay, so the theory of EBP is, well, it's elegant, but the way it gets implemented in the real world, that can be a lot messier. And this gap between the ideal and the reality has sparked some pretty intense debates, which we're going to get into right now. One of the biggest and most heated critiques really boils down to this fundamental conflict. What happens when a model that was designed for one-on-one patient care gets picked up and used for administrative, financial, or even policy reasons? And this is where the rubber really hits the road. Researchers like Driscoll and Grady have pointed out that insurance companies and big healthcare organizations, they often use the language of EBP, but they use it to create these rigid lists of approved treatments. And what often drives that? Cost savings. It's a way to manage budgets, but in the process, they can effectively kick the patient values and clinical expertise legs right out from under the stool. This whole conflict over how EBP is used opens up an even deeper, more fundamental academic question. What do we even mean when we say evidence? And maybe more importantly, who gets to decide what kind of evidence counts the most? So here's the core of the issue. The EBP movement created this hierarchy of evidence, and right at the very top, it put randomized controlled trials, RCTs, because, well, they're fantastic at showing cause and effect.
But a lot of critics push back hard on this. They argue this creates a dangerously narrow view of what counts as knowledge. They talk about many ways of knowing, and they point out the irony that RCTs themselves depend on concepts and measures developed through other types of research, the very kind of research this hierarchy often dismisses.
Which brings us to our final and I think crucial way of looking at this. When you consider its huge influence on funding, on policy, on what even gets taught in schools, it becomes clear that evidence-based practice isn't just a clinical tool. It's a full-on macro-level social movement. I mean, think about it. EBP is a force that is actively reshaping entire professions. At the highest level, it's shaping government policy and directing where the money flows. At the agency level, it's dictating what services can be offered. It's changing what gets taught in universities and what counts as a legitimate fundable practice. It's so much bigger than just a single decision between a clinician and a client. And so that leaves us with this really critical question. If EBP is a powerful social movement that can define what's legitimate and control the money, then the debate over what counts as evidence and who gets to be the one to decide, well, that's not just an academic debate anymore. It's a conversation about power, about professional autonomy, and really about the future of knowledge itself.